Assalamu alaikum everyone. So on the behalf of the PSA Karachi chapter, okay, I welcome you all. So today our presentation is on anesthesia of assessment in chronic osteoarthritis patients. So this lecture will be presented by Dr. Zara Rizwan. She is a consultant anesthesiologist at Indus Hospital, Karachi. She is experienced in preoperative assessment for such patients. This is the first talk on the module of orthopedic and trauma module. So I will hand over this presentation to Dr. Zara Rizwan. She will present on this topic. We will answer to all questions at the end of that presentation. So if anyone want to ask any questions, so they can type on the chat form and then we will reply at the end of the our session. Okay, Dr. Zara Rizwan, over to you.
Assalamu alaikum. Good evening, everyone. Thank you, Dr. Nasser. My name is Dr. Zara Rizwan. I am working as consultant anesthesia at the Indus Hospital, Karachi. Today, the topic of my presentation is anesthesia assessment in chronic osteoarthritis patients. So, moving on to the introduction. Why does chronic osteoarthritis matter to the anesthetist? Well, whenever the patient presents for any joint or spine surgery, the major concern is usually the population is quite older, they have limited mobility, they have issues related to chronic pain, and they have multiple comorbidities, which are usually present at that age and point of time. The anesthetic assessment therefore extends beyond the affected joint. It's usually not just the hip or the knee, but it's beyond that. The functional capacity of the patient and airway and spinal mobility, the cardiopulmonary reserve, medications, analgesia requirements, positioning, and post-operative rehabilitation is all the concerns which we have to look for during the anesthesia. So, as a trainee or as a consultant or even as an anesthetist, we need to identify the modifiable risk before surgery and develop an individualized plan that supports safe anesthesia, effective analgesia, and early mobilization. So by the end of the session, I will be able to help the participants in order to describe the systemic and functional impact of chronic osteoarthritis on anesthetic risk, perform a focused preoperative assessment tailored to osteoarthritis patients, identify the airway, positioning, and cardiorespiratory concerns in such patients, as well as choose appropriate anesthetic technique that can be either neuraxial anesthesia, that can be either the regional analgesia, anesthesia, and the general anesthesia. So, optimize medications, analgesia, and post-operative recovery planning. These are all the steps which we have to go and move one by one. So pathophysiology that is relevant to anesthesia is usually the osteoarthritis is primarily a degenerative disease. It's not the systemic one, but like a rheumatoid arthritis, but as it is chronic, that matters a lot. There is progressive cartilage loss that results into pain, stiffness, deformity. There is secondary muscle weakness and deconditioning around that joint that results into altered gait and posture in the spine, and basically the airway positioning challenges. Basically, there are airway and spine related challenges that we face during the perioperative period. There is also, so basically today the topic of presentation is the preoperative assessment in patients with chronic osteoarthritis. Our learning objectives are based on the systemic and functional impairment related to chronic osteoarthritis and its effects on the anesthesia, the performance of focused preoperative assessment that is tailored to osteoarthritis patients, identifying the airway, positioning, and cardiorespiratory concerns, choosing appropriate anesthesia techniques that can be either neuraxial, regional, or general, and optimization of the medications, analgesia, and post-operative recovery planning also. So the pathophysiology that is relevant to anesthesia in cases of chronic osteoarthritis patients is usually osteoarthritis is primarily a degenerative disease. It's not systemic inflammatory like rheumatoid arthritis, but chronic effect matters. So there is progressive cartilage loss leading to pain, stiffness, deformity. There is secondary muscle weakness and deconditioning around that joint. There is altered gait and posture that leads to spine and airway positioning challenges also. There is chronic pain sensitization that leads to most of the pain, as most of the patients are already taking higher doses of analgesia for their chronic pain, so there is higher perioperative analgesia needs. Most of the patients are already suffering from obesity and metabolic syndrome. Most of the patients have this also in coexistence. So although rheumatoid arthritis has more airway, spine, and systemic changes, but osteoarthritis is always functional positioning, and there are certain concerns related to it. So if we move on towards the preoperative assessment, it is based on structured osteoarthritis focused preoperative evaluation. If we talk about the structured one, so then we need to assess the disease extent and function status of the patient, airway, cervical, and spine mobility. That is most of the times restricted. The cardiopulmonary reserves, as we have most of the geriatric patients in cases of chronic osteoarthritis. The pain, opioid use, and analgesic plan has to be discussed priorly. The medications and comorbidities, because most of the patients are usually suffering from hypertension, ischemic heart disease, and diabetes, as well as OSA. So the medications needs to be optimized. There is positioning limitations and challenges that we need to face during the whole perioperative period. The anesthetic technique selection is again individualized on the patient's condition, and there is post-operative disposition and rehabilitation needs that needs to be started as early as possible. So if we talk about the history, in cases of chronic osteoarthritis specifically, we need to assess the disease and function. We need to assess the joints that are involved, the duration for how much time the joints are involved, and the severity of the joints involvement, like the patient is either to walk or there is need, or either the patient is on wheelchair or requires the assistive devices for moving. There is any history of falls, the daily activity, living and limitations which the patient is facing. Is he able to lie flat or climb up the stairs, or is he completely immobilized? The prior joint replacement or spine surgery history is important. The pains and medications, as I have told before, that there is multiple comorbidities in most of the geriatric patients. We need to assess the pain and medications which the patient is already taking. The baseline pain scores, as the patient is already on chronic opioids, NSAIDs, gabapentinoids, antidepressants, maybe taking the steroid injections and the intra-articular steroids. So we need to assess all that. Over-the-counter analgesia and supplements has to be assessed as well in our history. The red flags related to history would be unexplained dyspnea, chest pain, syncope, or there are any OSA symptoms, severe OSA symptoms, anticoagulation or any bleeding history, or if there is any previous difficult airway or anesthetic complications. For function status and risk. So if there is poor mobility, as we know, most of the patients are limited because of their chronic condition. They are unable to move around. So we need to assess the practical markers. We need to use the practical markers for assessment of their mobility. Most of the times their maths is masked because of their mobility. So we need to assess whether they can climb up the stairs, how many blocks they can move. So we need to assess their maths equivalent when possible. Ability to transfer and lie supine, we have certain frailty indicators like weakness, weight loss, exhaustion. So we need to assess all that also. Whenever there is reconditioning, there is increased risk of post-operative pulmonary complications in such patients because of their already cardiopulmonary reserves are reduced. There is increased risk of delirium in such patients. There is delayed immobilization post-operatively also, and there is increased risk of venous thromboembolism. So we need to assess and optimize them preoperatively as much as possible. We can rehabilitate them. We can ask to correct the anemia. I'll share later how would we do that. Airway assessment in osteoarthritis patients. So osteoarthritis is also, although less airway critical than rheumatoid, but still we need to assess the limited neck extension and flexion movements, especially in cases of cervical spondylosis or facial osteoarthritis. The temporomandibular joint osteoarthritis is going to result in restricted mouth openings. So that's going to be the airway difficulty which we can face. There is increase. There are some patients who have the thoracic kyphosis as well as lumbar stiffness that results into difficult positioning for intubation and anticipated difficult airway. The obesity and the OSA is highly common in situations, and that is also going to result in high risk airway. We need to assess them for malumpati, mouth opening, thyroventral distance. The cervical range of motion is very important. We need to assess that, although it's whether it's active or it's pain limited. Dentation, beard, prior airway difficulty, if there is any, or stop bang and OSA risk has to be assessed. In case of any difficulty or anticipated difficult airway, we need to prepare the video laryngoscope, RAM positioning, and difficult airway card should be ready. Cardiopulmonary evaluation. So for cardiac, there is age as well as osteoarthritis related lifestyle, which we need to assess. That is going to give us the mirror image of their cardiac status. There is high prevalence of hypertension, coronary artery disease, heart failure, and arrhythmias in such patients. Limited exercise, as I have told before, there is limited exercise that is going to result in masking of the angina and reduced capacity, and the underlying cardiac disease is most of the times masked because of the limited movement and the immobilization. So we need to follow the standard guidelines for further testing when function capacity is not going to be evaluated. For pulmonary, there is restrictive patterns from kyphosis, obesity, and immobility. OSA is again obesity or hyperventilation syndrome that can be either there, and we need to assess that. The smoking-related disease like COPD can also be there in cases of chronic osteoarthritis patients. For preoperative condition, what we can do preoperatively is to continue most of the cardiac medications, although A's and ARBs are individualized. We need to optimize the volume status and blood pressures among such population, and we need to screen and plan for OSA also, like we can prepare the CPAP and BiPAP for the immediate post-operative recovery area. Muscular, skeletal, and positioning assessment. It's although critical and often overlooked. We need to assess which joints can be moved without severe pain. Can the patient tolerate supine lateral? Because in total hip replacement, we have to keep the patient in the lateral position. And sometimes there is also the prone position for certain osteoarthritis patients. We need to assess priorly in the pre-op area which joints are already involved and there is limited movements in such joints. Fixed flexion deformities of the hip and knee has to be evaluated. Spine deformities should be evaluated. And there is also the risk of pressure injury during the perioperative area because of the compression over the bony prominences like elbow or wrist. So we need to assess that and document that because it is going to help us in our post-operative assessment of the patient. We need to document the safe ranges of motion in most of the joints, padding and support should be there in case if there is any risk related to joint movement or for the pressure injury risk. Need for extra personnel should be there for transfer, and there's risk of nervous stretch compression, so we can prevent that by doing the proper preoperative arrangements for such patients. Medication review. So most of the patients are on already on, as I've told, there is a chronic pain condition. It's a chronic pain condition, so most of the patients usually taking the painkillers and the over-the-counter medications like NSAIDs, which increases the risk of bleeding, renal, and CVS. We can hold if there is increased risk of bleeding or renal injury, but we can continue the low dose strategies among those who can tolerate that. Opioids are most of the is basically the option which most of the patients are already taking, and we can continue that basal needs and follow the multimodal plan. But we know there is high chances of tolerance and hyperalgesia those who are taking opioids. Acetaminophen is usually the generally safe option which patients are taking, and we continue that because it's also in our ERAS that I'll share later. Duloxetine and SNRI is most of the patients are taking antidepressants, and their sudden discontinuation will result in withdrawal and bleeding. Although rare withdrawal symptoms are most of there, so we usually continue them. Gabapentinoids are usually avoided in elderly population in higher doses, but can be continued in low doses. Anticoagulants and antiplatelets if you are planning for neuraxial anesthesia. So we need to hold that, or either we need to bridge that depending on the patient, and we need to coordinate that with the primary team. Chronic steroids are, although less commonly taken in osteoarthritis patient, but if taken, it can result in adrenal suppression. So we have to consider for the stress dose. Herbals are usually hold 1 to 2 weeks whenever possible. Investigations, the usual investigations is usually the CBC, because we need to assess the anemia before major joint surgery, as it can lead. Renal status has to be evaluated by going for the creatinine, urea, and electrolytes has to be evaluated, because patient is already on NSAIDs or ACE or ARBs, as well as the age is also an indication for renal function evaluation. ECG, because again, the comorbidities may be there, and there is age suggestive ECG changes, which we have to know before surgery. Coagulation studies, if there is bleeding risk or anticoagulants intake. Selectively, we can go for a chest X-ray if there is pulmonary symptoms, or there are pulmonary symptoms, or either the spine or cervical spine deformity. So we can go for chest X-ray. We can go for echoes or stress testing for cardiac risk algorithms. HbA1c in diabetic population can be done. Albumin and nutritional markers in trial patients, because we have most of them are geriatric, so we can go for albumin and nutritional markers. And we need to avoid the unnecessary testing that does not change management or perioperative plan. So there is a summary of recommendations for modifiable risk factors, like because it's actually an elective surgery, we can optimize patient, and it's better to optimize the patient before going for such a surgery. So it's better to ask them for the body mass index to be below 40 kilogram per meter square prior to the surgery. Diabetes has to be controlled, and it should be, the HbA1c target should be lesser than 7%. Aim for smoking cessation at least 4 weeks prior to the surgery. Opioid use should be minimized and should be avoided and should be discouraged. Anemia should be routinely checked, and it should be corrected if required. Malnutrition, again, because it's the frailty indicator, because so we need to consider it for patients. If there is serum albumin levels below 3.5, we can consider referral them to a dietitian preoperatively. There is risk of poor dentition, again, so we can get a dental review if possible. Vitamin D deficiency is most of the patients are suffering from, and we can get the supplementation preoperatively in order to improve the vitamin D levels. Anesthetic techniques option. So we can go for either the neuraxial anesthesia, we can go for regional anesthesia with the peripheral nerve blocks, or either we can go for general anesthesia, or we can go for the combined techniques, that is general anesthesia plus regional anesthesia. So neuraxial approach, like a spinal or epidural, is most of the times preferred in case when there is no contraindications. If it reduces the risk of pulmonary complications as well as postoperative nausea, vomiting, and opioid requirement also. For regional peripheral nerve blocks, like for TCA patients, we can go for femoral, adductor canal, IPAC, or sciatic nerve blocks, or for THR, we can go for fascial or pericapsular plans also. For upper extremities, we have supraclavicular block or interscaling block, as well as opioid sparing and rate. It's basically the opioid sparing and rate for multimodal analgesia. General anesthesia is important in patients whenever there is patient refusal, there is any contraindication for regional, or either there is the positioning needs to be prone in cases of spine surgeries. It can also be considered whenever there is airway related issued airway concern, or if there is any airway concern, typical airway concern, we can go for the general anesthesia. The combined approach, like a spinal or peripheral nerve block plus GA, can be considered in patients also. Each neuraxial, whether or general anesthesia, both have their own pros and cons, and it's not again individualized as per the patient. It's not a general rule to go for neuraxial only or general only, or either to go for the combination. We can consider it considering the patient's requirement and the surgeon's requirement. So favor neuraxial and regional is favorable whenever there is lower extremity arthroplasty, if there is no coagulation or infection related issues, if the patient is going to accept it, and patient has better understanding of neuraxial, and there is desire for reduced systemic opioids. in the intraoperative as well as postoperative period. We prefer GA whenever, as I have told, there is prolonged or complex or spinal surgeries, airway insecurity after sedation, there is risk of OSA or severe reflux with unprotected airway concerns in deep sedation, inadequate block or surgeon request for complete immobilization is also an indicator for going for the GA. So it's usually the team decision. It's a shared decision that improves patient satisfaction. So intraoperative priorities is always like we have to go for the careful padding and neutral joint alignments, avoid forced range of motion beyond perioperative. If we have assessed the preoperatively the joint limitation, then it's going to be better for us during the intraoperative period also to assess and to minimize the joints which are already affected. Hemodynamic stability, like cementing, especially blood loss, tourniquet release, is usually the periods in which we have hemodynamic instability, and we need to address that if it happens. Tranexamic acid can be given when there is no contraindication. During the intraoperative period, we also need to manage the temperature. Antibiotic timing is again important because most of the times they are taking the cultures, and antibiotic has to be coordinated with the surgeon. Multimodal antiemetic and analgesic regime should be the one. Glycemic control is again our concern. Venous thromboembolism prophylaxis planning should also be implemented. There is semen implantation syndrome if it occurs, and we have to be ready related to it. We have to increase the FiO2 volume, vasopressors, and the better communication with the surgeon is the key. Analgesia strategy, that is ERAS, because it's now the era of enhanced recovery after surgery. So basically we go for the ERAS, like we can schedule acetaminophen, we can plan for NSAIDs or COX-2 inhibitors in case there is no bleeding or serious related or renal related issues. We prioritize regional and local infiltration technique for ERAS strategy. Cryo and early mobilization is also a concern. We can go for low dose ketamine infusion instead of opioid infusion in cases when we have the selected opioid tolerant patients. Dexamethasone can also be given because it's going to act as an analgesia as well as going to reduce the risk of post-operative nausea vomitings. Gabapentinoids can be given, but it should be used with caution in older individuals. Opioids can be given in low doses, but we have to keep in mind their chronic tolerance and withdrawal symptoms, which happens if they are discontinued. So we have to control the pain as much as it enables the physical therapy and does not produce the deeper sedation. We have certain special populations for the chronic osteoarthritis, like elderly. Basically, we have to prevent the delirium. We have to adjust their doses and prioritize the regional techniques among them. So of course, we have elderly population in majority, so we have to consider this all. In obesity and OA patients, we have to maintain the airway and ventilation planning. And basically, there is also risk of venous thromboembolism. Opioid tolerance, as I have told before. So for that, patients, we need to continue their basal requirements of opioids, and we need to prepare the regional and multimodal strategy. Acute pain services should be involved earlier in such patients. Whenever there is bilateral or revision surgery cases, there is high chances of blood loss and physiological stress. So we need to strictly monitor the patient. We have, because how can we prevent the venous thromboembolism? Because it's one of the major complications that occurs in most of the chronic osteoarthritis patients. So we can go for the mechanical and pharmacological prophylaxis, like we can go for TED stockings and earlier mobilization and earlier physical therapy. We can start the anticoagulants and antiplatelets whenever possible. The skin integrity and infection risk is again an issue, and if the patient is diabetic, so it can occur earlier. We need to treat the anemia preoperatively whenever time allows to us. Glycemic optimization is going to help in the postoperative infection risk also. The smoking cessation counseling should be done. Weight and muscle strength rehabilitation improves outcomes. So we need to coordinate with orthopedics, primary care, and geriatrics. It's actually a multimodal approach which is going to help the patient. Postoperatively, we can go for the Baku pain and block resolution monitoring. We need to watch for the respiratory depression, urinary retention, nerve injury. We need to mobilize them as early as possible. Rescue analgesia pathways has to be counseled to the patient in case they develop pain on the way home. Sample pre-op. So these are all the things which we have earlier discussed, that like pre-operatively we should document the joints which are involved. We should assess the airway and C-spine and temporomandibular joint. What's the risk? Function capacity should be assessed. Cardiopulmonary risk should be stratified. Anemia should be checked. Renal function should be checked and should be optimized. Positioning and padding plan should be there. Multimodal analgesia is ordered, and thromboprophylaxis, as we have discussed priorly. Post-operatively, this position. So it's a functional and positioning disease with major anesthesia complications. Assessment must go beyond the surgical joints, like it's not the airway spine, as I've told before. Regional and uraxial anesthesia techniques are often advantageous for extremity surgery. Multimodal opioid-sparing analgesia is again important for ERAS program. Careful positioning prevents nerve and soft tissue injury. Best outcomes can come from pre-operative optimization, ERAS principle, and early mobilization. These are some of the references and guidelines which I have taken from. So, any questions?
Thank you, Dr. Zara. Please ask any question if you have.
Anybody has questions?
So if you don't have any questions, so please fill this Google form I have posted on our chat.
Excuse me, sir. Excuse me, sir.
Yeah. Yes.
Madam, how
Yes.
can we find cardiac reserves and osteoarthritis patient? Means a patient can't walk. Oh, so how can we find has cardiac reserve?
We can, as I've told, we can go for the specific testing in cases we cannot assess. Like we can go for a normal echo as well as a stress echo. We can go for the exercise tolerance test if required. So it's usually the advanced technique and advanced like echo stress testing. These are all the parameters which we can order in situations whenever the FC cannot be determined. Or is there any risk related to them?
Okay,
Ji, sir,
we have
one more
another.
question.
Okay, you can ask. Okay.
Do you have any experience of cryotherapy and pain management?
Not currently. We are not practicing that cryo, although, but to be honest, but it's written like in ERAS program, we can go for it.
Okay, there is another question that my question is that what monitoring would you like to use?
Intraoperatively, you are asking?
I don't know, but there's a written that my question is that when Khalil Ahmed asked that, my question is that what monitoring would you like to use?
Monitoring would be basic if it depends, it's again individualized on the patient. If the patient is like having no comorbidities, then we can apply these standard monitors. Like if the patient is if the patient is having heart failure or is there a known case of ischemic heart disease, so we can go for the specialized monitoring, like we can go for arterial line monitoring. We can apply the CVP and we can get the CVP monitoring also. Otherwise, we have to go for the standard monitoring.
Okay. Any other question by anyone? One important thing, please fill this feedback form. That is very much important to get a certificate. No questions? Okay, anyways, thank you, Dr. Zara, for this nice
Thank you.
presentation. Very good presentation.
Thank you,
Thank you,
sir.
everyone. Allah Hafiz.
Thank you, sir. Thank you so much.